Good morning. Today we'll be talking about eradicating leprosy. Thank you very much. It's a pleasure to have you, Dr. Ayesha and Dr. Roberts, on the program. Thank you very much for being here with us. Tell us, what is leprosy? And why is there so much fear of it?
So leprosy is a bacterial disease caused by Mycobacterium leprae. From the dermatological aspect, it affects the skin, the mucosa, and the nerves. It's a condition that occurs all over the world. There's no race that is spared. However, so many countries all over the world have eradicated leprosy. However, there are 5 countries that still have leprosy cases. And of those 5 countries, unfortunately, Nigeria is one of them. Why does it cause so much stigma? It's the disability that comes as a result of the infection, which is one, not recognized, not treated properly. And so it runs its course, and subsequently they have a disability. The disability could be from the nerves. So you have the mutilation of the hands and the feet, deformation. You can also have the eyes affected. And of course, the skin, which has terrible ulcers, which are difficult to heal. So it's those 3 things, getting to not allow the disability get to its total final end appearance. That's what brings about the stigma that we have.
Wow. Now, Dr. Roberts, can you just step in here and talk a bit about it from the public health perspective? The theme for this year is called United for Dignity. Can you tell us?
Thank you very much for having me. And Dr. Akinkugbe had given us the background of this. Leprosy is one of those diseases. It's been mentioned in the Bible. It has had this stigma from ancient times. However, from the public health point of view, number one, like you said, it is imminently preventable and imminently curable. The problem we have is awareness. Because people don't come in time for treatment, diagnosis and treatment, it tends to go on. And it's one of those diseases, it's very slow to catch. So you need a long time of exposure to anybody with leprosy to be able to catch leprosy. But because it's one of those diseases that causes this horrible disfigurement towards the end stage, you've got this high sense of stigma that is associated with it, and therefore people don't come out early enough. Also, you find that even when people complain, maybe they've seen the spots on their skin or they've got this loss of sensation on their skin, somehow even physicians don't have a high index of suspicion. And because it's not something you see every day, it's not something you think about. Now, this is assuming the person even gets to a physician. Most and generally, people end up at the patent medicine vendor and all kinds of, side by side, inappropriate, what I call inappropriate healthcare. And that further delays the diagnosis. Now, it's one of those diseases that because there was a massive program of control, I think that started in the late 60s, if I'm right, all through till about the 80s, there was a massive reduction in the number of people that had leprosy. But then again, we now became victims of our own success, in the sense that because there were now so a massive reduction in the number of people, it kind of dropped off the radar because other diseases became more, as it were, came up front and center. The malaria is still an issue. HIV/AIDS is still an issue. Tuberculosis is still an issue. So a lot of physicians still have this very low index of suspicion, and that is now leading to this issue. So when we say Unite for Dignity, which is a fantastic theme for this year, what we're trying to do is bring back that sense of, listen, you may have a disease called leprosy or Hansen's disease. It is not a reason for people to shun you or I mean, in those days when there was no treatment, perhaps, but now we've got a fantastic arsenal of drugs and therapies that can be applied, and it is eminently curable. Curable means that it can be gotten rid of completely.
Oh, I think that's actually very encouraging and very important for people to know. I mean, the disease has actually been one that uh, people have singled out over the centuries. Look at how Jesus picked out people with leprosy to cure them. Someone like Mahatma Gandhi actually very strongly advocated for the condition. And to know that there's treatment for it, I think is important for people to be aware of. Dr. Aisha, so talking about the um, diagnosis, Dr. Roberts has mentioned the fact that the diagnosis is made far too late. So, how do you, in your dermatological clinic, Dr. Akinkugbe, how do you make that diagnosis? And how do you recommend that any doctors listening to this program now should approach this condition?
Okay, so what we have is, unfortunately, if you walk into the clinic, the patients that walk in there, as soon as they come in the door, we can already tell they have the condition because the telltale stigmata are already there. That's not what we want. So that's what we get. Now, like Dr. Roberts had said, what we want to do is catch them earlier. So to the doctors out there and to the other healthcare practitioners that we have, because unfortunately, that's the way it is. Before they come to the doctors, they would have gone to the patent medical store dealer or the pharmacist. A light patch, sometimes it could be dark. Any complaint of, I can't feel a sensation there, or you simply just check with a wisp of cotton wool. Those are the telltale signs. However, if the light patch has been treated by someone, in whatever form, with a topical corticosteroid, because that is what they use, or an antifungal agent, and it hasn't improved, more light spots are appearing, the ideal thing is, if you don't know what it is to refer to the dermatologist. That's the best that can happen. But if you're a seasoned physician, you can also look. I mean, about leprosy. You need to have that high index of suspicion. You can check for the nerves. You can look at the face. There are telltale signs as well, which might not get to the end stage. But if you're finding papules that are becoming nodular, it's gone on for a long time, you can also try and find out where they reside. But what I find in Lagos now is that we just see patients that have lived in Lagos all their lives and they have leprosy. So the public health physicians know that despite what we're saying about decreasing numbers, we are still seeing cases. They're being missed, even in terms of reaching the state and national grid in terms of being captured. So that is the problem. Then, of course, if they should come with an ulcer that is just, not going anywhere. So a wound, that's what I would say. But for medical terminology, an ulcer that's not going anywhere. You can also have loss of eyebrows, the hair on the eyebrows. That is, typical of a type of leprosy, which we call the lepromatous leprosy. You can have nodules, painful, tender nodules, bumps and lumps. So these are the ways that we would like them to either make the diagnosis or have a suspicion and then send to the dermatologist. But I think the key message is whatever skin condition that you're seeing, that you've treated in whatever way that you can, and it is not getting better, seek the help of a dermatologist. That's it, really.
Bottom line. Dr. Roberts, could you carry on from what she said?
Yes, now she did mention this thing about, having to see, because everybody believes that because I did not live in a camp filled with people with leprosy, it cannot be leprosy. I've lived in Lagos all my life. So that's one of the major errors that a lot of us are making, myself included, needless to say, because one assumes that if you live in a highly urban area, you are not going to get it. But considering that globally, over 100,000 new cases were picked up, I'm not sure if we have the actual figures for Nigeria, much less Lagos. It tells you that it is still a problem. And the problem, like Dr. Aisha quite rightly mentioned, is early diagnosis. So one of the things that we would be very keen to do is to train healthcare workers, particularly our community health extension workers, our community health officers, to be able to identify very quickly, even if you just make it a screening of the people that come into the clinic, just take a look and see whether there are any light patches, any skin discolorations or anything, and get people to understand that, look, early diagnosis is the best thing that we can have. We don't want you coming in when the disease is already well established in the body. We do need you to come in early. We need you to have that high index of suspicion. We need you to not treat skin conditions with all these, what I would say quite boldly, are funny creams that are for sale in the chemist and the patent medicine vendors, because it doesn't help in the long run.
Yes, it just actually clouds the diagnosis and creates more problems for the patient, particularly since those stigmata that developed, they're not reversible.
No.
I think that's a huge challenge. How about contact tracing? Is contact tracing done for cases of leprosy?
Contact tracing should be done, and I believe it is, because we've got very good systems for contact tracing. But Dr. Ayesha, your thoughts?
I think that better liaison between us and community health, where we can have an established, just like, let's just use COVID for instance now. Anybody who's COVID positive, because everything is all linked. When you test positive, the team is doing the contact tracing. So I think there is a little bit of a gap, but we on our own do it. But I mean, just I'm stuck in my clinic. I don't have field workers. So I think this is something that Dr. Roberts and myself,
something we need to work on.
We can work on. But usually for all our patients and contacts, we just give them a form. We try and find out who's in the family, and then we write forms for them to go and have the skin slit and smear test, which is done, But unfortunately, there can be lags in that, definitely.
No, I think very important, because back in the day, I remember that, contact tracing was a big thing. And there was a huge amount of contact tracing done for TB, for this, for that, for the other. And for some reason, it seems to have really gone down. But with COVID and the resurgence of the understanding of the importance of contact tracing, I think this is really an opportunity for us to really put that on the front burner and try and eradicate, because that's what we're talking about here, trying to say, and can I ask that question? Is it possible to eradicate leprosy?
Yes. All over the world, as of, the year 2000, it had been eradicated except in these 5 countries. So yes, it is possible. But then, we also have factors that are unique to us.
What are those
poverty,
factors?
overcrowding, malnutrition. Then we do have the displaced, the what's it called? How do we put it? The conflicts, in different parts.
Situations, yeah.
Yes, all of that plays a role, but it's not like we're still trying to highlight. We are still getting leprosy in the urban areas and in the cities. So it's also migration, everything. Everything's playing a part. And there's a resurgence of a lot of these so-called neglected tropical diseases, of which leprosy is key.
Thank you very much. Thank you, Korede, for coming on the program and sharing your experience with us.
Yes, ma'am.
Can you tell us, how did you find out you had leprosy or Hansen's disease?
Okay. Good afternoon, ma'am. Thank you for this opportunity. Far way back 5-6 years ago, I think apparently 2017. Yes, it started in the form of scabies, like itching and other body, what's it called? Other body.
Had a rash.
Yes, exactly. So it started that way. Yes.
And then where did you go?
Yes, firstly to the pharmacist, took some medications, then it left. Then later on, it came reoccurring. That was when I was still in school. But then I stayed alone though. So I had to come to Lagos and I approached the hospital there.
Where were you? Where did you grow up? Where did it happen?
Yeah, I think it happened then in Ibadan. In Ibadan.
Okay.
Yeah, so I
Okay.
came to Lagos and I went to the hospital because when it was coming constantly, like rashes and all stuff. And most time happens whenever I just finish taking my bath. You understand? So that's when I feel the rashes coming in. Before I started having the white pale, the light skin patches.
Okay. So when you
Yeah,
had the light skin patches, where did you go to and how was the diagnosis made?
yeah. Firstly, I approached the hospital. Then I was told it was microfilaria. Yeah, I
Which
was told it was
hospital did
micro.
you go to?
Um, I think that was Abbey Road Hospital.
Okay.
Yeah. So I went there for a couple of times, I think 2 to 3 times. It was the third time I went there. Then I sat the doctor down and I told the doctor, I don't think this is what is doing me. I think you have to probably refer me to a dermatologist. You understand? Because I felt there was more to it. You
Okay.
understand? Because when they said it was, yes. So the
And when
doctor
you went to the
understood my plight.
dermatologist?
Yes, when I went to the dermatologist at the first
Visit?
yes, the first visit to the dermatologist, he told me it was answers. You understand? So I understood. Yes. And even before I told them what was doing me, they already saw everything and they already, and it was just sort of same thing that was happening. So they told me and I understood. They placed me on medications.
Okay.
Yes, I was
And
placed on medications.
how long ago was this?
Yeah, that was 20, have you said third dermatology? That was 2018.
So have
2018.
they told you, are you in remission now? Are you cured? What have they told you?
Yes, I'm much more better than I was before. Like totally cured now, totally cured.
Okay.
Because yes.
And have you had any issues with people stigmatizing you or any issues like that that you're speaking out now for United for Dignity?
Not at all. Reason being that when it happened first and I noticed it, I tackled it immediately by visiting the dermatologist, which I think was the best solution anyone could have ever done or thought about.
And so now it's over and there's no stigmata, nothing. So we thank God
Not
for
at
that.
all. Not
So
at all. Not
what
at
kind
all.
of advice would you give to somebody else who was seeing some of these kind of light patches on their skin? What advice would you give them?
Yes, apparently, I think the best thing is just that whenever they notice that they have this the light patches, the first thing they should ever think is is for them to go to the dermatologist first. That's the first thing because they are the ones that will tell you this is what it is their job and they do it well. They are well good at that. So I think that's just it because when they keep using because okay, I didn't tell you I use medications. I even use traditional medications before I went to the hospital, but there was no improvement at all. But when I went to
Okay.
the hospital and I was diagnosed, and yes, I went for the clean slate and smear and the other test and everything. So and when it was basically noticed and everything was just cool
Treated.
thereafter. Yes,
Thank
yes,
you. Thank you. Thank you so
yes,
much for
ma'am.
sharing. Thank you.
Yes, you're welcome. Ma'am. You're welcome. Ma'am.
Dr. Akinkugbe, so just talking about Korede's case, obviously he's very fortunate. You were talking about different kinds of leprosy. Was his the better kind, the easier kind, or it was just that he came in on time? That was the reason why he was so fortunate, or he is so fortunate now.
In Korede's case, there was no disability. So definitely he would have a good outcome. And that is because he also at some point put his foot down and sought care, specialist care. So that's a good thing. But whoever comes really with the drugs, the multi-drug therapy is excellent. You will receive your cure if you're adherent and compliant with your medications, but it's the issue of disability. So obviously, if the nerves have been affected, and it's a disciplinary approach, because we also, they would go to the physical rehabilitation unit, putting in splints, in the hands or the feet, so that you don't get the foot drop and things like that. So if any of those complications have set in, it's either we try and improve it, but if it has really gone quite far, then there's not much that can be done, but we just try and rehabilitate, and whatever can be done, try and make them, live their lives better with that problem. So like you started off in the beginning, it's awareness, increasing this awareness, picking it up earlier when people have skin problems. So in the community out there, like Dr. Roberts had mentioned, and then really and truly, I mean, we've done the Dermatology Association, we've done several talks whereby we're having update courses with the pharmacists, with the GPs, just trying to increase awareness, amongst the other healthcare practitioners that we find in our states and in our nation. So if they can pick it up faster, I think that will help.
Thank you. I think also one of the things that is important is also to do contact tracing. And I think if we can you tell us, did you find out the source where Korede got it from? Is it always possible to find the source of where a person has gotten leprosy from?
Many times, I can't categorically say that each time we find the source, but I know that for a lot of those who come from out of state or have lived, outside Lagos and then have recently, moved to Lagos, we've been able to trace it back to someone in the family or, the extended family. But in Lagos, we just really haven't been able to pinpoint or pick any direct relations, So we just screen, we encourage them. It also depends on the setting, depends on the setting and the exposure of the individual. Korede himself, as you can see, is educated. He knows what's right and wrong and is ready to comply, However, you don't get that because there is that innate fear. They don't even want to, they don't even know how to go. So what we do say is bring your relatives, come to us. And then we now try and talk. But, I can talk to you and then you leave. I don't know what goes on. So this is where I think now the next step that we are going to take, since Dr. Roberts and I are in the same institution, is institute the contact tracing, because they know how to get to them in the community. They know how to follow up. I can only say, come, I can talk to you, but I can't go back to you. So I think we need to take it to the community. That's the key message here.
Yes, now communication. One of the things a lot of people are afraid of, they feel that all you have to do is touch a person and you can get leprosy. Now, is that correct, or does it take a lot longer than that?
Totally incorrect. And Dr. Roberts had mentioned earlier, it has such a long incubation period, anything from 1 to 3 years, but it can extend to 20 years. So that's also why many people can't even pick up where they may have, gotten contact. So that long incubation period doesn't help, but it is not, you can't pick it up by sitting next to the person. It is by close contact. Close and a little bit prolonged. So not I spent the night in my friend's house, or I slept, I stayed with an auntie for 2 weeks. You know what I mean? So that's it, really.
It has to be a lot more than that. Dr. Roberts, can you just expatiate on that a bit more? What is incubation period for those who don't understand it?
Well, incubation period is the period of time that elapses between contact with an agent that causes disease and manifestation of the disease. So using COVID, for example, everybody is so well versed with COVID. The incubation period of COVID is anything from 2 to 10 days, which means that, you've had contact with the person, and within 10 days, you will start manifesting the disease. So when we say the incubation period for leprosy, Hansen's disease, can be as much as 20 years, you can understand why the contact tracing is not so much geared towards finding the source of the infection as making sure everybody who is exposed or could possibly have the infection gets access to treatment. So the focus is a little different with the leprosy, in the sense that if we were, Korede, you don't mind if I use you as an example, we'd want to see all Korede's contacts, friends, family, people he has lived with or is living with for several years, to make sure they do not also have the earlier stigmata, so that we can get them quickly into treatment and cure, 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 cure. This is one disease where I'm so happy to say cure, cure, cure. Cure is the outcome we're looking for. Cure in a dignified manner. And I must add my comments to Dr. Aisha's. There is an advantage, a huge advantage, when you're dealing with people like Korede, who are educated, who are exposed, and who know that this thing, there's something wrong here. I am going to seek specialist care. And yes, he did do a bit of a roundabout the merry-go-round a bit, but it got to a point where he said, you know what, this thing is not what you say it is. Refer me to a specialist. And he did get a specialist care. And I'm hoping, Corey, that we can leverage on your success to be a voice for dignity, to get people to say, hey, enough of this already. Let's get to specialist care. So some of the things we're going to work on is that, because we get people who come to the primary health care centers a lot, and we're getting a lot more of them now that we're doing the vaccine rollout, we should establish a protocol where people are being inspected very quickly. It doesn't take a few minutes. And if there's anything that we are not terribly happy with, we make sure we get a specialist to take a look and tell us what's going on here.
Is leprosy gender selective, i.e., is it more common in men or women? And is there a particular race in which leprosy is dominant? Dr. Aisha?
More men are affected than women. No race is particularly affected. All races can get leprosy. However, like I mentioned earlier, it's been eradicated in I think there are 173 countries in the world, and there are only 5 countries that have leprosy endemic currently.
Which ones are those?
Myanmar, Brazil, Nigeria, India. One more, can't remember.
Dr. Alero, in the break, we spoke about this issue that Dr. Akinkugbe has just brought up, and the whole issue of how do we, tackle this matter? How do we take it forward? What can be done? Because we've reached a certain point, and now it looks as if the gains of that initial leprosy program are being lost. Leprosy is resurging. What can be done? What needs to be done?
Well, this is where we need to leverage on our successes in other diseases. So looking at how we pushed polio out, and the strong involvement of private sector in making sure we covered that last bit, that very last bit, to get rid of polio. Looking at the way we had the private public sector partnership with Ebola, latterly with COVID, looking at the amount of work that we've been able to do with the private sector in HIV, and in making sure people get trained. So the key issue here is being able to train and retrain healthcare workers. And I mean, there are just not enough specialists. There will never be enough specialists in Nigeria for this. So people like Dr. Aisha need to be able to replicate themselves several times over in physicians at the primary healthcare level, even community health extension workers and community health officers, community pharmacists, so that they stop just making money selling things that are of no use, but actually being able to point people in the right direction. And there's the other key thing. So looking at, leveraging on the example that Korede had, you live in one part of the city and you have to travel all the way to the dermatology clinic right across town in Yaba, and then travel all the way back. So even though the drugs are available for free, access to the drugs is actually costly. And this can be a very big turn-off for a lot of people, because they think, look, in the grand scheme of things, I haven't paid house rent, and my children's school fees, this one hasn't eaten, oh, my mother is sick, and this and that. We need to have much stronger financial risk protection to be able to push this last one, because if we can take this one off our radar, it will be fantastic, so that we don't have to be in those 5 countries that are endemic with where leprosy is endemic. We can actually have that private sector involvement, strategic private sector involvement, not just throwing money into a big pot, but strategic private sector involvement, something like strategic purchasing for success, where we can actually push the last bit out. So when we're talking about this, let's even just use the contact tracing, for example. The contact tracing would now go far beyond just his immediate family and neighborhood. But would also be looking at his workplace or his school place, for that matter, or where he used to live 3, 4, 5 years ago. So that kind of thing requires some private sector involvement for us to be able to move it along, as it were.
Thank you. Dr. Ayesha, can you tell us all the other symptoms of leprosy? You had mentioned there are different types of leprosy. How do we distinguish between the two?
Okay, well, first of all, let me just mention other symptoms. You can have a stuffed nose, a blocked, stuffy nose. You can also have blood coming out of the nose, what we call epistaxis. You can have the loss of sensation, so you don't feel, you have patches on your skin where you don't feel, you don't sweat. If it's your fingers, you might not feel things. Touching something cold, you don't feel it. Then ulcers, then painful bumps on the body. I mentioned earlier, just to recap, loss of the eyebrows. Sometimes you can have a disfiguration of the face, and then bumps, nodules on the ears as well. And talking about the different types of leprosy, you have 2 types. So you have the main 2 types. You have ones where you have the patches, okay? That's light and dark skinned lesions. And then you now have the other type, which is the lepromatous leprosy, where you now have, that's more advanced. It's a different type because you're not able to mount an immune response. And then you have what we call the leonine fasci. So those are the ones that have nodules on their face. You find the wrinkling, the forehead is all wrinkled, and the face, has that characteristic look where everything is just a bit because of the infiltration. So those are the 2 types. And then you have in-between stages, but I mean, to discuss that on radio would be a bit hard, But
are both types treatable? Are both types curable?
All types are treatable. All types are treatable. Like I mentioned earlier, the issue is the disability, the degree of disability.
Okay. Do children get leprosy? And how, if they do, how can leprosy be prevented in children?
A child will definitely get it from a parent, likely the mother, So it's really making sure that, one detects it early in a mother who has it. And as I said, part of the contact tracing, making sure that, okay, a woman who has it or a father, with young children around, we contact trace and follow up being the key thing. Because you see, a person who's had contact with someone who has had leprosy, after a year, the person will be like, okay, I don't have it. And that's it. 2 years, 3 years down the line, even 5 years, the person is married, is now in Sokoto, for instance, and maybe this happened in, let's say, Ogun State. That person is actually not going to really think about leprosy. That's the general truth. You know what I mean? But of course, there might just be that person. So that's why it's that counseling session where you sit, just like you cancel for HIV/AIDS when you want to test the person, the pre-test, the post-test. Same, if we have a laid down procedure where we have the facilities to actually cancel and contact trace properly and adequately, then hopefully, you can imagine if we had a network, and everything is global. Everything is computerized. Somebody's, picking it up in Sokoto, do you understand, or wherever.
Yeah.
Then you have your database, So I think, things will get better. Like Dr. Roberts had said, we just need to push this last mile so that we can be off that. I'm too embarrassed and I'm not happy that Nigeria is still, listed, but it is what it is. So we need to get off that list.
No, and I think the opportunity for yourself and Dr. Roberts to make that difference here and now is very, very key at this time. The last question, it says, what is the origin of leprosy? How was it first discovered, please?
Well, it had been in the literature for as far back as forever. However, what really brought it to the fore was in 1873, when a scientist, a Norwegian scientist, whose name was Gerhard Henrik Hansen, and he discovered this slow-growing bacterium, which is called the Mycobacterium leprae. And so as a result of that, it helped, that actually pinpointed what the cause was. It was a bacteria. They had other drugs that they were using, but then, there was a lot of monotherapy initially and a bit of, experimenting. And then gradually they started, I think they used dapsone initially, and then they came up with a multi-drug therapy, which I think was in 1995, and WHO made it completely free. That's like we mentioned earlier, it is free, but I tell you, sometimes they run out of drugs. And the problem is the program. We have problems with the program. So there's just one place in the state where you get it, where it should be at the centers, the primary health care centers. It needs to be decentralized so people can have access to it. We are lucky they're in our backyard. They're next door to us. However, it's not under us. It's the state. Do you understand? Just like TB. So why can't I, at my clinic, in the hospital rather, why can't, leprosy drugs be available to the patients? So the person is coming from Agege or coming from Ayobo or wherever, they all have to come to that one place on Harvey Road to get their drugs. That needs to change.
Well, thank you so much. I think the important thing is for us to advocate for change. I don't know who's going to do it, whether it's yourself or Dr. Roberts or both, but I think certainly now is the time. And also because we also have a very progressive Commissioner of Health, perhaps now would be the time to actually ask for this and perhaps things could change. Do you have any last words for our listeners?
Leprosy, curable. Early diagnosis is important. It is totally curable, and you do not have to stigmatize anybody that has it. All you need to do is point them in the direction of a specialist.
Dr. Akinkugbe, any last words?
My last words would be to everyone out there, particularly other healthcare personnel. Social media is out there. We have contacts. Things have changed over the years. You can reach us. You can find us. At least there are ways of finding us. When the skin condition is not adding up, it's not getting any better, it's okay. It's part of your professional service to know that you don't know what it is and you should refer. It doesn't belittle you, and the person in question, the patient, should understand that knowledge to be able to refer is excellent and is commendable, because you want the person to seek better help where they can get it. So that would be my message. Please, let's stop the use of mixed potent steroids for every single rash. Like Korede had said, he applied something and it disappeared, it got better, which is what would happen. So we need to really just up the ante in terms of awareness, and we need to do the right thing. Patients need to do the right thing. Healthcare providers need to do the right thing.
So without further ado, I'd just like to say a very big thank you to you, Dr. Akinkugbe, and to you, Dr. Roberts, and a very, very special thank you to you, Korede, for sharing your experience with us. It's very important. I'm hoping that it will change a lot of minds and help a lot of people come to treatment quickly, and also We hope that it'll also help to demystify leprosy and let people know that it's nothing to be afraid of anymore.